Hello everyone. Let us start with our part 2 of binocular single vision. So let us start with abnormal retinal correspondence. Before learning about ARC, we should know what normal retinal correspondence is. In normal binocular single vision, there is fixed physiological relationship between the corresponding retinal points of the two eyes. That is, the fovea of one eye is the corresponding point with the fovea of the other eye. Both foveae have the same visual direction. This arrangement is known as normal retinal correspondence. So what happens when the squint develops? Due to ocular misalignment, images fall on the non-corresponding retinal points. This leads to diplopia, that is two images of the same object, or confusion, that is two different objects which are perceived together. Coming on to the definition of ARC, it is a condition in which, due to an active cortical adaptation, the fovea of the fixing eye, that is the normal eye, and extrafoveal point of the squinting eye acquire a common visual direction and act as corresponding points. Okay. So what is the mechanism? It is seen mainly in children, especially with early onset squint, and in with children with small angle esotropia. So here brain reassigns visual direction to avoid diplopia and confusion, and hence resulting the fovea of the normal eye is corresponding to the extrafoveal point in the squinting eye. Basically, it is an adaptation. So it is an adaptive but abnormal sensory state. It helps the child tolerate squint and makes treatment of squint more difficult because of the presence of intractable diplopia after the squint surgery. So these are the differences between ARC and suppression. One of the two differences which are very important is it is an adaptation. ARC is an adaptation and suppression is an inhibition, because in suppression there is active cortical inhibition of the image from the squinting eye. So the purpose of both of them is to avoid diplopia and confusion, but in suppression binocular vision is absent, simultaneous perception is absent, as well as stereopsis is absent. These are the most differentiating features from the ARC. All right, coming on to the problem after squint surgery, it causes ARC causes intractable diplopia, and if the patient is had suppression, there is usually no diplopia. It might lead to amblyopia if prolonged treatment is prolonged. Okay, so these are the major differences which we should remember. ARC is a cortical adaptation. Suppression is an inhibition. In inhibition, there is no single vision, binocular single vision, and there is no simultaneous perception, and hence stereopsis is also absent. Okay. Now, coming on to the tests to detect abnormal retinal correspondence, we have these 5 tests: Worth-Fodor test, Bagolini striated glasses, after image test, synaptophore, and the Titmus stereo test. So, first of all, let us start with the Worth-Fodor test. In this test, the patient is asked to wear the glasses. The red glass is in the front of the right eye, and the left glass and the green glass is in the front of the left eye. All right, so a normal response is 2 green lights and 1 red light and 1 a mixed light, which is a normal response. If the patient is having normal retinal correspondence but with squint, he is seeing 5 responses. But if the patient is having left eye suppression, so this means he is not able to see the green color, so that is why he is able to see 2 red dots. If the patient is not able to see the red dots, this means there is right eye suppression, and hence the patient is seeing these 3 dots, 3 green dots, leading on to the result of right eye suppression. Okay. Coming on to the interpretation, when the patient sees 4 lights, then this is the normal single vision, normal fusion is present. But if the patient is seeing the 4 lights with the presence of manifest squint, this means this is abnormal retinal correspondence, which means there is an amylous fusion. Okay. If the patient is seeing only green lights, 3 green lights, this means right eye image suppression is seen. If there are 2 red lights, this means left eye image suppression is seen. Very easy to remember. 3 green and 2 red are seen alternatively, then there is alternating suppression. Okay. And if there are 5 lights, then this means there is diplopia and there is no suppression, and hence there is no fusion. Seeing 4 light does not always mean binocular single vision. We need to consider the presence or absence of the squint. So therefore, that is why this test is only useful to detect suppression, detect diplopia, and suggest abnormal retinal correspondence. Why? Because abnormal retinal correspondence mimics normal fusion on Wurzford test. Diplopia indicates absence of both suppression and fusion. So just to summarize, 3 green light means right eye suppression, 2 red lights means left eye suppression, 5 light means diplopia, and 4 lights with manifest squint, then this is the abnormal retinal correspondence. Coming on to the second test, that is the Bagolini striated glasses. These are the glasses in which one glass is having the striations at 45 degrees and the other glass is having striations at 135 degrees. Patient fixates on a single light point, and these are the questions which need to be answered at the end of this test. The first question is, how many lights do you see? All right, and second is, how many lines do you see and where do they cross? Now, patient wears the glasses, fixes on a single light point. So if the patient is sees two lines, then the next question comes, do the lines cross the light? Like in this case, if yes, then there is a normal binocular single vision. If the patient is having two separate lights are seen, then there is diplopia. If these lines do not cross the light, then there is abnormal retinal correspondence. And in this case, if there is only one line seen, then this means there is suppression. Okay. So another slide, just a repetition slide. Two lines crossing at the light, normal. Only one line, suppression. Two lines but not crossing at the light, then this is abnormal retinal correspondence. And two separate lights with lines, then that is diplopia. Okay. If they are crossing two lines but they do not cross the light, then this is abnormal retinal correspondence. Okay. Why Bagolini test detects ARC better? The key reason is it is least dissociating test and most physiological test of binocular vision. Why? Because there are no colored filters involved. All right. Second is there is no dark room involved and the patient uses everyday binocular mechanism. It allows anomalous fusion, and hence allowing anomalous fusion, as it is a subtle cortical adaptation, it doesn't, and Bagolini glasses do not break fusion, and hence ARC is expressed rather than masked. It also detects shallow suppression. All right, and it represents real life vision. Okay, so that is why Bagolini test detected ARC better, and why? Because it is least dissociating and it is the most physiological test because it does uses the normal everyday binocular mechanisms, and it also allows anomalous fusion, and hence ARC is expressed rather than masked. Okay. Now coming on to the third test, that is the after image test. In this, each fovea is stimulated separately. It eliminates fusion and suppression and it directly tests true retinal correspondence. Very important. So what is the procedure? So right eye is stimulated with the vertical bright light and left eye is stimulated with the horizontal bright light. Patient is asked to draw the position of the images. If there is a perfect cross, everything is normal. If this vertical line is shifts towards the left, then there is esotropia with ARC. If this vertical line shifts towards the right, then there is this esotropia with ARC. Okay, so this is how the interpretation is. Why after image test is important? Most reliable test for ARC. It is independent of fusion and suppression. It demonstrates true retinal correspondence. It shows the true sensory state by eliminating fusion and suppression. Bagolini test reflects day-to-day binocular vision, and ARC may appear normal on Bagolini but is unmasked by the after image test. So these are just one-line Viva answers for your last minute revision. Most physiological test for binocular vision is Bagolini test. Most reliable test is after image test. Least dissociating is Bagolini test. Most dissociating is our after image test. So now one word, one line here. What test screens binocular vision? Bagolini reflects daily binocular function, and after image test reveals the true retinal correspondence. All right. So now coming on to the another mechanism, that is diplopia. So diplopia is the perception of two images of a single object. There are two kinds of diplopia, binocular and a uniocular diplopia. In binocular diplopia, it occurs due to the formation of images on dissimilar retinal points of the two eyes. It disappears when either eye is closed. Very important causes of binocular diplopia. These are usually asked in exams. Extraocular muscle paralysis is the most common cause, which occurs because of the third, fourth, or the sixth nerve palsy. Displacement of the eyeball, which can be caused by orbital tumors and orbital wall fractures. And mechanical restriction of ocular movements because of thyroid ophthalmopathy, thick pterygium, or a symblepharon. Optical causes, which include decentered spectacles causing deviation of light rays, and anisoconia due to anisometropia, which is marked image size disparity due to occurring because of uniocular aphakia corrected with spectacles. Okay. Coming on to the types of binocular diplopia, there are two types, uncrossed diplopia and the crossed diplopia. In uncrossed diplopia, false image appears on the same side as the deviated eye. Occurs in cases of convergent squint. In cases of a crossed diplopia, images falls on the opposite side. It occurs in case of a divergent squint. I will show the diagrammatic representation at the last. Coming on to the uniocular diplopia, double vision persists even when the normal eye is closed, indicates a problem within the affected eye itself. Causes of uniocular diplopia include subluxated clear crystalline lens, subluxated IOL, double pupil effect because of congenital anomaly or a large PI or iridodialysis, incipient cataract which usually causes polyopia because of multiple water clefts in the lens, and the last one is the keratoconus because of the irregular corneal curvature and resulting in different refractive power in different corneal areas and hence resulting in uniocular diplopia. To treat diplopia, definitive treatment is to treat the underlying cause, like treat the nerve palsy, optic disease, refractive correction, or cataract surgery. So, to have a symptomatic temporary relief, occlusion of one eye is advised. Usually, the affected eye is occluded, which eliminates the disturbing diplopia. Now, this is the last slide of this presentation, and in this, I want to show that crossed and uncrossed diplopia looks like. So, in case of a crossed diplopia, which is seen in divergent squint, and an uncrossed diplopia, which is seen in a convergent squint. So, in convergent squint, image from the deviated eye, it falls on the nasal retina as the fovea moves temporally. Nasal retina projects image onto the same side, and hence the false image seen on the same side as the deviating eye. So in case of exotropia, image from the deviated eye falls on the temporal retina. Why temporal retina? Because now the fovea has moved nasally. So temporal retina projects the image to the opposite side, and hence the false image is seen on the opposite side. So this covers our binocular single vision topic, which I have tried to cover in part 1 and part 2. From the next presentation onwards, we will be studying strabismus. So before we go on to strabismus, all these concepts should be crystal clear in your mind. Then only we will be able to understand the mechanism and the treatment of strabismus. Thank you. See you in the next topic. Thank you.